Hi, this is Professor T.Valenta, and I will guide you through the lecture of the interview and culture for Health Assessment N125. We'll be talking about how to collect information from people by talking about their health, their illnesses, their perceptions of health, and also what their expectations are from the healthcare providers and the environment. Part of what we'll be doing is developing a trust and rapport in order that we can talk to people and educate them about their health care. We found that many people under the age of 65 die of preventable illness, and if we could take a holistic approach to gathering information, many of these illnesses might be caught much earlier and people will have a longer, healthier life. In this class, you're going to learn to do a complete health history. You'll be doing an older adult health history, so it's lined up exactly like this lecture. Very important to understand that all of the history is subjective. There is no physical assessment involved. It's about questioning the health beliefs and expectations of your patient, learning about their lifestyle, their families, along with any concerns that they might have. So it starts with biographical information, basically who they are, where they're from, and if they have a doctor or provider that they see on a regular basis. CC is the chief complaint. We also call it the the reason for seeking care. And that is put in parentheses. It's a short statement by the patient, such as, I have a stomach ache, or my head hurts, or I have a rash. Then we go to the history of present illness, which is where we do our loud carts. And that's when we start asking the questions about the reason for seeking care. And loud carts, PQRSTU, old carts are just acronyms. Doesn't matter which one you use as long as you're getting a thorough amount of information and not forgetting any specific parts. So as we go through it, you could bullet point that on your older adult health history or write it as if you were saying it to another person. The past medical history, PMH, is just that. It's talking about past hospitalizations, past surgeries, immunizations, and any comorbidities. Comorbidities are concurrent conditions, meaning the person comes in with a reason for seeking care, and it may or may not have anything to do with the other comorbidities that they are dealing with, such as hypertension, hypercholesterolemia, rheumatoid arthritis, or some type of cancer and chemotherapy, or eczema, or some other disease process that's chronic. Next, we go to social history, which is asking about where is this person within their environment? What type of community do they live in? Are they safe? Where, if you were going to tell them after an interview that there are some things they could do for health prevention, health promotion, and you said you should take a walk every day. Well, if they're in an environment that isn't conducive to that, maybe there's a high crime rate, you could come up with some other ideas, such as walking in a mall or something like that. Family history is about who they are in the family. Are you a mother, a father, a partner, an uncle? Who is important in your family that lives nearby that you can call on when you're sick or if you need help? And this is a part of the history that in the hospital we could actually use that to know who to call when a person is really upset or needs to be sat with. This will also include your family pedigree, which you can refer to your textbook on page 53, and it will explain exactly how to write up a pedigree. For this class, I expect 3 generations. So, for example, if you were the patient, you would have your information, your parents, and your grandparents. The next is the review of systems, which you reviewed in lab, and it's a series of questions that are offered in a systematic approach so that you cover each system. It not only includes the issues a patient might have, but it also includes the health promotion. For example, if you're doing mouth, then you would also, other than saying the mouth is free of lesions, ulcers, no halitosis, teeth are in good repair, are snug to gum lines, things like that, you will also have the health promotion of patient flosses twice a day, brushes twice a day, sees the dentist every 6 months for a cleaning. Next, you'll go to client profile, and you could look at that as the nursing report. It's how you pull everything together that you learned from this person and put it in a very succinct 1 to 2 paragraph closure that ties everything together. For example, say that your patient was complaining of blurred vision. That was the reason for seeking care. And then as you go through your review of systems, you find out that their skin has become very dry, that they're always thirsty when you talk to them about their nutrition, or that they're fatigued all the time, and maybe in the GU section you find that they have frequent urination. So maybe it's diabetes. Now, it's not your job to diagnose, but you could start looking at that and grouping that information based on what you know from pathophysiology. That will come in time. I know we're at the beginning of your journey in nursing school, but eventually you'll be able to tie these symptoms together in some cohesive manner so that when you're talking to the provider, you're giving them the information that they need to know. There are 4 different types of databases depending on what clinical situation you're in. There's the complete, episodic, follow-up, and emergency databases. Complete is like when you go to the doctor for your annual visit and they do a full health assessment and a full physical assessment. Episodic is, for example, if you go to your doctor because you have a sinus infection or chronic headaches, or maybe urgent care because you think you broke your foot. So it's problem focused, and it's driven by what you need to know to fix that problem. The follow-up visit is, say that you had an episodic visit and now you need to go to follow-up either to get stitches out, a cast removed, or just to make sure that there's no bacteria in your urine. An emergency visit involves a rapid gathering of information as you perform life-saving measures. So those are the 4 databases for health history. Again, the health history is only subjective information. There is no physical exam, no objective information included in the health history. Remember that the patient knows everything that you need to know about them and how they're dealing with different issues of health, but you have to be able to pull it out with the questions that you ask. So the goal of the interview, or gathering a history, is to gather subjective information and to pull together a database or a collection of data. You want to find out what the mutual goals are of your patient, because it is patient-centered care, meaning the patient needs to be in the middle of all of the decisions, and again, they know what you need to know, you just need to pull it out. 90% of assessment is history taking. Only 10% is actually doing the physical exam. So your health history will drive you to what you need to examine with your physical exam. So in conclusion, the interview process is about gathering data. It's about establishing a rapport with your patient so that they will tell you what you need to know. And so that you develop that connection so that they feel safe with you and that you can provide health education in a non-threatening manner. The patient, again, is the partner in their own care. They are the center of what we do. And the next part of that interview process would be to educate about their health. So the interview is a contract between you and your patient, and it consists of spoken and unspoken rules for behavior so that your patient knows what is expected of you and what's expected of them. The terms of the contract include when you're going to do this interview, how much time it's going to take, why you're doing the interview, which is a huge important factor that I can't express enough, that you need to express to your patient why you're asking the questions that you're asking, especially when you ask questions about culture, race, sexuality, drug use, alcohol use, and maybe even when you ask questions about GU and GI, like the urination and defecation. People get very anxious when you ask them private questions unless you give them a clear indication of why you're asking. You should let them know how long it will take if you can. So if you're walking into a patient's room and you're doing the initial history taking of a patient that's just been admitted to the hospital, you might say, I need to ask you some questions. It's going to take me about 15 to 20 minutes. Do you need to go to the restroom before we get started? That way it gives them a little sense of how long you'll be there, and they can be more comfortable while you're doing it. You need to let them know what's expected. And you might say things like, you know, I will be asking you some very personal questions. If you're uncomfortable answering those questions, you have the right to decline. Hopefully, by the end of the interview, they'll feel comfortable enough with you to give you more information if needed. If there's other people in the room, it's up to the patient whether they'd like them there or not. However, it's very uncomfortable if their family is with them, you go in to ask questions, and you ask them in front of the family, is it all right if they stay? Because often they feel like they have to allow that, when in fact maybe they're very private about their personal health condition and behaviors. So if you can, ask the patient when you're alone with them of, I need to ask you some personal questions. Should I ask your family to leave before I begin? Okay. And also letting them know that the information is confidential to a point. We have the HIPAA regulations that prevent us from discussing any information about them that with people that are not directly involved in their care. But they should know that the information that you're gathering can go to nurses, the providers of care, and to the insurance companies that are directly involved with their care. Also, it says to disclose if there's any cost. Typically, the nurse is unaware of insurance and costs and things. That would be something that an admissions person comes in to talk to them about their financial obligations. That's when that's discussed. So with the process of communication, which is included in any time that we are speaking with another person, we're usually trying to develop some type of rapport. So from the time you first meet someone, you are already kind of figuring out who they are, how they relate, if you can relate to them. Now 7% is through words, 38% though is through tone, tempo, and the timbre. So if a person is talking monotone, I really don't care, just give me the answers, that's very different than saying, please tell me more about what's going on. The remaining 55% comes from physiology, so that's unspoken body language. And body language includes your posture, the gestures that you're using, your facial expressions, blinking and breathing even. So that means that, for example, if we were doing some of the tools that you learned in our reading of matching, mirroring, cross-matching, using a tone of voice consistent with the other person, or matching words, any of those are ways that you're going to build rapport. For example, if the person moves his leg, you can do the same thing by crossing over, using your hand, crossing over the other way. Or you could match the breathing of a person. It's very interesting when you do that often if a person's breathing very quickly, I wouldn't match the breathing. I might do a head nod with each breath and then slowly nod my head slower and see if we can get the patient to subconsciously slow down the breathing. It often will work. It may not be very obvious at first, and it depends on why they're breathing so quickly. If it's anxiety, this will work. If it's shortness of breath, that's another story. You need to treat that. But this is all called neuro-linguistic techniques. And so please read the required reading assignment for this class so that you have a good idea of how to use these different techniques. They're just more tools for your toolbox. Patients depend on the nurses to help get them better. And so the process of communication involves a mutual understanding of what you're telling the patient and how they're interpreting it, and vice versa. So the process of sending is how we communicate what we want to tell someone, and it's through our behavior, again, through the tone, the timbre of your voice, and through the nonverbals. So all behavior has meaning. So be careful of your facial expressions, of looking at your watch because you're in a hurry. Maintain eye contact. Foot tapping can be used when you're trying to match a person's breathing, for example, but don't do that as a unconscious, hurry up, I need to get this over with. With receiving, the receiver is taking in information that you're giving, and they're perceiving it based on their cultural background, their past experiences, and also by their current emotional state. For example, when I'm giving you one of the quizzes, and I give you instructions on the Scantron, and I say fill in the key ID, it's A for quizzes, and then I go on to say now fill in the number of your student ID. Many of you are so nervous about the exam or the test that you can't really interpret the information and follow direction. And it's not because you're a dummy or that you're not listening. It's that emotional state is getting in the way. So keep that in mind when you're talking to people that are having a health crisis or in a lot of pain. Often they just can't comprehend everything that you're saying. So often you're going to have to repeat yourself. You might even write things down for them in an effort to help them receive your information. So communication is a tool, just like any of the other tools that you're learning in this class. For example, you learn tools to help deal with pain, like creative imagery or deep breathing or hot and cold. Those are tools that you put in your toolbox so that you know things that you can offer for your patient. With communication, you also have tools like the matching, mirroring, ways to build rapport in an environment that's so fast-paced, and you don't have a lot of time, so the rapport building needs to be fairly quick. There are internal and external factors of communication. The internal factors include things like, do you like people? Can you feel empathy for what they're going through? Do you have the ability to listen and really hear what they're saying? The external factors are things like ensuring privacy. For example, asking the family to leave while you're asking questions, or closing the drape between the two patients in a room and standing closer to the patient so that your voice doesn't have to carry over so that other people aren't hearing what you're talking about. It also includes the lack of interruption. For example, if you're about to go do something for 15 minutes in a patient's room, you should buddy up with your other nurse and say, I need to be in there. It's going to take me a little while. Can you watch my other patients just for the next 15, 20 minutes so that I can do this without interruption? And that's not uncommon to ask for that. We also want to make sure that the physical environment is free of a lot of extraneous noise like TV or radio, and that it's well lit. Because remember, if people can't see your facial expressions or your gestures, they may interpret what you're trying to say. So make sure that the room is well lit. As far as note-taking goes, there's nothing wrong with taking notes. However, when it becomes a crutch and you're standing there with your clipboard and the paper and you're writing notes, or if you're on the computer next to the patient and you're going through and asking one question at a time and doing the notes, often that prevents a flow of communication. It prevents the rapport building. So, because you need to have eye contact, you need to show that you care. And in order to do that, you can't be standing there and just writing every word down, because it's as if you can't remember from one sentence to the next what they're talking about. Things that I typically write down would be numbers. I always write my vitals down, even before I record them in the computer, because I'm so afraid I'm going to forget them before I even get there. I also record or take notes on things like if it's the right side versus the left side, because I don't want to document incorrectly. So, or if you have a number of how many milliliters of urine you just emptied out of the urine bag, things like that, it's okay to write those notes. And a clipboard can be cumbersome, so carrying a little notebook in your pocket might be a good way of just keeping the little highlights that you need to remember before you chart. There's nothing wrong with taking notes. However, be aware that there are pitfalls of note-taking. It will cause you to break eye contact often as you're writing notes. It shifts attention away from your patient. It interrupts the flow of conversation. So if you ask an open-ended question and then you start taking notes immediately, you might miss a lot of the physical gestures or the emotions that come through in facial movements. And it also could be threatening to the patient, especially as you're writing down really sensitive material, like, for example, something about their sexuality or their the consumption of alcohol or drugs. So the first phase of the interview is going in, introducing yourself, telling the person who you are, what your role is, and the reason that you are about to ask them questions. You don't need to start with small talk, although some people do, but it's not necessary for building rapport. Often you'll build rapport just based on your competency and the fact that you're there acting as a professional. You want to make sure that the TV and radios are turned off. Social distance is considered to be 4 to 5 feet apart. Often you'll be moving the bed up to the right height so that you can be at eye level with your patient, and standing near the bed so that you can hear each other. The next phase of the interview is the working phase, and this is when you're gathering data. You'll be using two types of questions. You'll be using the open-ended questions and the closed questions. An open-ended question would be something like, tell me about your pain, or I've heard you're having abdominal pain. Can you tell me more about that? It doesn't mean that it has to have a question mark at the end, but it's still offering or asking a question that expects more than a 1 or 2 word answer. Now, a closed-ended question would be something like, so tell me about the severity of your pain. When you look at a scale of 0 to 10, what number would you rate your pain? That expects a one-word answer, so that's a closed-ended question. Each of these have a different place in the interview, and you'll go back and forth using both.
Start your assessment by taking a detailed health history to obtain subjective data. The information you gather during the interview will provide insight into the patient's actual or potential health problems and guide your physical assessment. To make the patient feel comfortable and respected, begin with open-ended questions.
What brings you into the office today?
Open-ended questions promote rapport, give the patient a chance to speak freely, and let him discuss the issues he's most concerned about. But when you want specific information, it's best to ask a direct question, such as one that requires a yes or no answer.
Do you smoke?
No.
Do you drink alcohol?
Also note the patient's level of consciousness, including his degree of wakefulness and orientation to person, place, and time. After obtaining the health history, ask the patient to empty his bladder and provide a urine specimen if needed, and then to undress completely and put on a gown.
This video will be an interview taking place in a clinic situation, and so it's a little different than what you'll see in the hospital, but it does have the same concepts of history taking that we use at the bedside.
Positive communication can help you deal with those negative encounters so common in healthcare. You know the ones. You're on top of the world, just radiating warm feelings, and then it happens. A negative encounter loaded with negative communication.
Could somebody help me? Anybody?
What is your problem?
What do you mean, what is my problem? What's your problem? I've been sitting in this room in this paper outfit for more than an hour, and nobody's bothered to even stick their head in the door, let alone examine me. Do you have doctors here?
Of course we do, sir. They're very busy. You'll just have to wait a few more minutes.
No, I won't have to wait a little longer. I'm going to put my clothes on, and I'm leaving here if you can't tell me when I can see the doctor. I do have other things to do.
Unfortunately, so does the doctor. He'll be with you soon.
No, he won't be with me soon. I'm getting dressed, and I'm out of here.
What did you think of this incident? Now, listen to this episode again. We've made some changes. See if you can identify some positive communication techniques that are used.
Could somebody help me? Anybody?
How can I help you?
I've been sitting in this room in this paper outfit for over an hour. Nobody's even bothered to stick their head in the door, let alone examine me. Do you have doctors here?
First, let me apologize, Mr.
Stevens, Tony Stevens.
Mr. Stevens. We're very busy today, but that certainly isn't your fault. Someone should have come in to talk to you and tell you how much longer the wait would be. Tell me, who's your doctor?
Dr. Berrigan.
If you don't mind waiting a few more minutes, I can run down the hall and see how much longer the wait would be. Would that help?
It sure would. I don't mean to be difficult, but I only blocked out a couple of hours for this exam today. I have a meeting at 3:30, and I'm going to be too busy for the rest of the week to schedule another appointment.
Mr. Stevens, I'll get that answer for you.
Thank you. I appreciate your help.
The employee's approach to the angry patient was certainly better this time. How did she turn the patient's attitude?
This video is great. It's going to show you the right and the wrong way of dealing with a patient who has been waiting too long in the exam room to see their provider. And you'll see the techniques that the healthcare staff takes to calm the situation. So open-ended questions are used to get a narrative response. Like I said before, more than a one or two word response. We often use them when initiating the interview, and we also use them when a patient brings up a new topic. Now the closed or direct questions, again, are used to get short answers. It's to provide you with direct answers to certain questions, such as, tell me about your pain. What does it feel like? Can you describe it? And that's asking, again, for just very specific information. These questions are also used to keep the interview moving along, so it's not getting stalled and taking way too much time as a person goes on and on, because many people have very long stories to tell. Facilitation encourages people to talk more, and by nodding your head, keeping eye contact, saying mm-hmm or I see, are ways to allow a person to communicate more. Reflection is a technique that we can use that echoes a person's own words, and by repeating part of what a person just said, it helps to express the feeling behind the words. For example, a patient might say that they just found out that the lump in their breast is cancer. I'm so afraid of, The response by the nurse might be, you're afraid that you may have breast cancer? This response is using part of what the person just said and also is using interpretation to confirm what the person is trying to say. An empathetic response recognizes the feeling and puts it into words. It names the feeling and allows the expression of it. It strengthens rapport. Other empathetic responses are, this must be very hard for you, or I understand, or just placing your hand on the person's arm. Now, using clarification can be used when the person's word choices are ambiguous or confusing. It can be used to summarize the person's words or simply to make the words clearer. It's an effective way to ask if you're on the right track. When the nurse uses the responsive confrontation, the frame of reference shifts from the patient's perspective to the healthcare provider's perspective, and the healthcare provider starts to express his or her own thoughts and feelings. The nurse should give honest feedback about what is seen or felt, but this may focus on a discrepancy, so the nurse may confront the patient when parts of the story are inconsistent. Interpretation is used when the receiver of information assigns their feelings to or makes associations with the verbal message. It's an inference or a conclusion about what's being said. It may help the person that's saying something understand their own feelings in relation to the verbal message. For example, when listening to a patient state, I can't take this anymore. If I have to listen to one more person say that there's a gold lining to living with the pain I'm in, I'm going to throw something. You might say, it sounds like a lot of people have been telling you that being in pain will eventually have a good outcome. Interpretation is not based on direct observation as confrontation is, but it's based on your inference or conclusion of what someone said. The nurse risks being wrong. If this is the case, the patient will correct it. But even if the inference is corrected, it may help promote conversation on the topic. Explanation is giving information to your patient. It's telling them the facts. It's explaining what's going on, what you're doing, why you're doing it. The reason that we give information during the physical exam is to build rapport with our patient. Summary is the final review of what someone said. It condenses the facts and presents your view of the health problem. It's a type of validation. So a person can agree or not agree, or they can correct you. And both people are participating. It occurs at the end of the interview, and it's signaling that the end of the interview is coming to a closure. So go to page 33 of the Jarvis text, and it will give you examples of the techniques that we've talked about for the verbal responses while interviewing a patient. On this list, we're looking at nonverbal skills such as eye contact. Can be very important, although some patients will not want to have eye contact with you. That's their choice. But we do want to look at our patients and show that we're interested. Physical appearance, you want to look professional. You want to wear your Samuel Merritt University uniform with pride and make sure that it's clean, that the white top is still white and not gray or spotted with blood or even pen marks. Make sure that your shoes are clean, because sometimes people will look down and not up if they're having a hard time and don't want to have eye contact. Your posture, just showing that you're open to listen and not looking at your watch and worrying about getting out of there as quickly as you can. Just look at your patient, have an open expression so that your arms are at your sides or at least not crossed over your chest. Using different gestures, trying to match and mirror gestures, as we've talked about, is a good idea. Facial expression, again, not having a scowl on your face or looking depressed or uninterested. Walk in and be friendly, and again, show your eye contact. And with voice, don't be monotone like a depressed person. Don't be, too exuberant. If you're walking in, for example, and you've got a family circling a patient who's about to die, so you're going to monitor yourself to the situation. We typically don't touch during the interview because it would be considered inappropriate. We haven't developed the rapport yet with the patient. The only time that we would touch is if we really know this person pretty well. And then with closing the interview, we want to ask the person, is there anything else that you wanted to talk about or anything that you might have forgotten to mention? And then say your goodbyes. We have 10 traps of interviewing to talk about. One is giving false assurances or reassurances. For example, when doing the SP and the patient complains that the mother had recently died of cancer, we don't say, oh, well, I'm sure you don't have cancer. There's so many other things it could be. Instead, we could provide an assurance that the doctor will be doing these tests today and will give you the results as soon as possible. Hopefully that will alleviate some of your fears. Giving unwanted advice. If someone doesn't ask for information, it's not appropriate to try to give it to them and just assume that they want to hear it. For example, if you have a personal opinion, if a patient asks you, so what would you do if da-da-da-da-da? Don't fall into that trap. What can end up happening is that you fall into being held accountable for what you say instead of keeping that accountability on your patient for making a decision. Using authority. Oh, the doctor says this is what you need to do, and you need to do it because it's what he said. That's just assuming that the doctor has authority over this patient. And really, we're looking at a holistic approach where the patient is involved in their care. Using avoidance language like passed away instead of death, or the big C instead of cancer. It's a way of avoiding what you don't want to talk about. Using distancing. That would be something like the prostate or the breast instead of my breast or my prostate. It's a way of distancing so that a person isn't truly taking their problem and personalizing it yet. It's one step towards that. Using professional jargon. I'm going to use the bell of my stethoscope to take your blood pressure so that I don't miss the oscillatory gap. Of course you're not going to say that to your patient, but some of us get fairly close to that when I say, for example, I'm going to take your systolic blood pressure now. They don't know what systolic means typically, and if they may ask, and that would be fine, but if we're constantly using words over and over, different jargon throughout a conversation, a person can't keep up, and they're not going to keep asking for you to explain what you're saying. Often they're just too tired to confront you about that. using leading or biased questions. You don't drink, do you? You don't use drugs, do you? Or tell me about your pain. Now, you don't have a sharp pain, do you? It's not stabbing, right? Things like that. That's leading in different ways. Also, talking too much or interrupting the patient. When you ask an open-ended question, give your patient a couple minutes to actually respond to you instead of interrupting. It's so easy to start with the right question of, tell me a little more about your pain, and then immediately going into, what does it feel like, or can you describe what it feels like, because you haven't given the patient time to think about what's important to them and what they'd like to use, or what they'd like to say to you. So be careful with that. Try to really give them time using your silent attentiveness. Using why questions. Why haven't you been to the doctor for the past 2 years? That's providing a judgment, or it could make a patient feel uncomfortable, like you're blaming them for not coming in on time if now they have something going on that we could have fixed if they'd been seen earlier. With kids, we've got to be careful because we're watching for dynamics between parents or caregivers and the children. We're trying to get information that usually children are unable to give us, that we need the parents or caregivers to provide, yet we don't want to ignore the child. However, initially it's okay to spend the time talking to the parent and just glance at the child a few times until they become more comfortable with you being there. There's different ways to deal with different age groups, and we'll be talking about that a little bit more. I know a lot of you want to work with children, work in pediatrics, and that's great. And you won't always have their parents at their bedsides, although often you will. But the big points on this are to use short, simple sentences that are understandable, that are concise, so children can understand. Be sensitive to their needs. Try to give them a chance to get used to the equipment that you're using. Sometimes I'll let them play with it a little bit, my stethoscope, for example, before I do anything, or let them listen to their bunny's heart rate before you listen to theirs. There's a lot of ways to deal with kids to just keep them a little bit more comfortable with the medical culture. Some people find adolescents to be the most difficult population to work with, and others of us love them. But we need to be very careful to respect and show the dignity and respect that they deserve, and also be honest and truthful. So to be successful with adolescents, the first consideration is your attitude. And you need to go in with that attitude of respect, not the attitude of authority. And secondly, you have to be honest. If they ask a question, you need to give an answer. I'm sure you're wondering why I put a picture of Dr. McDreamy on the slide, but who wouldn't want him as a doctor or as the father to your child? Just kidding. But with pregnant women, we need to be very careful because we're not just working with the pregnant woman, we're dealing with a family, we're dealing with the baby. So when you work in maternity, labor, and delivery, you never have one patient, you have at least two. So we want to make sure that we build the rapport with the mom so that she can feel comfortable asking questions about baby's care or breastfeeding, whatever the educational topic is at that moment. I think this might be my favorite slide. I would love to be 90 years old, happy, healthy, have a boyfriend or a husband, and swinging on the swings on a beautiful day and just enjoying life. We need to watch our older adults and remember that they were young once too, and that often they see themselves as much younger than we see them. Often you may not think that you'd have anything in common with a person until you start talking to them and realize that inside they have the same thoughts and feelings that you might have. They worry about the same things. They just have lived longer, maybe a lot wiser. But we want to draw on their experiences and be careful when you go in that you are going in with the attitude of respect. Try to build a rapport so that you can continue educating as needed. Be careful if there's sensory or visual loss. Remember the steps of providing a good place for interviewing, for having turning the radio and TV off, making sure that the lights are on so that they can see your facial expressions, and check to see if they can hear you. If they're asking you over and over, can you say that again? Maybe there is a hearing issue, or maybe you need to talk more clearly. Working with disabled people, be aware of what their needs are and try to adapt to them. For example, if they're in a wheelchair and all curled up, you need to be able to get into a position where they can see you, that you can have the direct eye contact. Remember that you are showing respect for this person no matter what disability they have, and just involve them to whatever their limits are. When dealing with people with special needs, for example, if they're hearing impaired, ask the person how they would like to communicate. Do they write things down, or do they want you to write things down, or can they read lips, or do they want an interpreter that speaks sign language? People that are acutely ill often cannot focus on a conversation and may be so ill that they're even unable to talk. They may be very short of breath, for example. People under the influence of drugs or alcohol may distort what you're saying and may not understand. So sometimes it's better to wait until they're at a point where they're a little less aggravated. The top priority for dealing with someone using drugs or alcohol is, when did you take your last drink, when was the last drug, and what was it, so that we have some idea of what the withdrawal issues are going to be for this person. If a patient becomes sexually aggressive or makes a sexual advance, it's appropriate to step back and say, I'm very uncomfortable with that behavior. I'm a professional and I'm here to help you. And if they continue to be that way and do not take your hints or your outright, I'm not comfortable with this, then that would be the time to leave and go to your charge nurse and possibly security. When someone is crying or looks like they're about to cry, bring a box of tissues, stay with them, acknowledge their feelings, and wait until they're done crying before you start talking. Don't just change the subject or continue asking questions when they're crying. Crying can be a relief and a way of cleansing, and it's just a good idea to just be there for them and continue the interviewing later after they're done. But don't just say, oh, I see you're upset, so I'll come back in a while. That's like a slap in the face. People that are angry and threatening violence, leave the room and call security. Sometimes you can de-escalate the situation, but by acknowledging that they're angry. But if they're actually threatening violence, leave the room and call security. And lastly, we're talking about people who are anxious. Almost everyone in the hospital is anxious for one reason or another. So by going in and trying to soothe and calm people, using your mirroring and matching and your other techniques of communication. There are going to be times that you feel like you've lost control of the interview when a patient goes on talking and talking and talking because maybe they haven't been listened to for a long time, or they don't feel that someone's heard them, or maybe they have a lot to say. So try to take the time to listen if you can, but often you're going to be in a time crunch and you've got to be able to get the information that you need so that you can start doing the treatments for the patient. So use your direct or close-ended questions to start redirecting or refocusing the patient into the areas that you're trying to glean the information. And over time, you should be able to assume control back. But this takes experience, so you'll learn tricks of the trade as you do this more and more.
Hello, Mr. David. How are you?
Good.
Good. All right. Oh, you know my cousin, Matt Tesler.
Oh, Matt, your cousin?
Yeah.
Yeah. Oh, yeah. Oh, right. Oh, thank you for this.
Yeah,
thing.
sure,
Yeah.
sure. So let me ask you, Mr. David, why are you here to see the doctor?
I just didn't tell the doctor.
No, it's okay. I'm going to take all the information first, then I give it to the doctor. So why don't you just tell me what's the reason you're here?
I know, but if the doctor's going to come in here, why not just tell the doctor? I don't see why I need to tell you, and then you tell the doctor.
Well,
why not just tell him directly? I'm going to New York. Why am I stopping off in Florida?
Policy is that I take the information down first, and I give it to him. He'll come in and go over this, so he'll have it all
Yeah.
written down. He won't have to go through all of the questions again.
This whole thing is askew, your system. The doctor should be in here right now. We could be saving
Well,
time.
he's got other patients that he's dealing with, so when I'm
all right,
here,
so
I pretty much cut the time in half
Cut
with
the
him.
time in
so
half. What, you
that-
intercept him in the hall? He's going to get the information and then what, run to the internet to look it up? No, he's going to
The
hear it from
doctors
you
and the nurses
and then come
work
in.
hand in hand.
I
just need the information. If you could just give it to me.
I'm not that comfortable telling you,
Well,
frankly.
I need to take it down before I can leave.
Okay. I have a gerbil up my ass. That's my problem.
How long has it been there?
2 days.
Okay.
Okay?
Thank you. The doctor
All
will be right with you.
Fine. Okay. Happy?
Mr. David?
Hello, doctor.
Larry, nice to see you.
Okay.
Now, I was wondering if you could tell me what seems to be the problem.
I find this video hysterical, and it's not as uncommon as you might think. Watch the nurse and observe the ways that she's treating this patient with facial expressions, the tone of voice. Also, she does something where she's trying to develop rapport where she says, "Oh, I think I know your cousin," but that, in fact, puts it on a personal level, and now the patient won't be able to express the problem without being really uncomfortable and worried that the information is going to be spread. So watch and learn. Learning to talk to people every day about their concerns and issues takes practice, and more practice. And it also takes learning the basic concepts and principles of interviewing. Do not be afraid of your Jarvis textbook. It's a great, very readable textbook, and the chapter on interviewing is phenomenal. Now we're going to shift gears a little bit and talk about culture, because culture influences our communication. Culture is dynamic, ever-changing, and learned from birth through the processes of language acquisition and socialization. I love this quote from Madeline Leininger. Having knowledge of a culture before trying to help a client and family is analogous to a nurse or a physician having basic knowledge of anatomy and physiology before doing physical assessment or attempting to meet a patient's physical needs. Culture has a profound effect on etiquette, the space and distance, like the American social distance, I believe is 4 to 5 feet, where the intimate space is within 1.5 feet of a person, where it may be very different in another culture. I know sometimes I feel crowded by someone when they stand too close to me, and I find that sometimes that's a cultural space and distance variation. There's cultural considerations about gender on patriarchal versus matriarchal societies. There's cultural considerations about sexual orientation, where some believe that transgender people are actually holy people and have more vision than others. When we look at healthcare management, we have to keep in mind that a person is coming from their own point of view, and it's based on perceptions and culture. And their compliance to what we ask them to do, like taking medication or doing something, lifestyle change, is going to have a lot to do with their background and their belief system. Religion impacts how they believe or what they believe their health is, and how illness comes to be. Some people believe that illness is a way of retribution for doing harm in another part of their life. Family impacts our belief systems too, and our perceptions. And we have family practices that we don't realize are what bind us together. Traditions in families are different, and even there's wide variations among different cultures and among each culture individually. End-of-life issues, really important to understand. If a person says, I don't want pain medication, it might be because of their religion. You can explore that. Some religions, a person does not want to have medication in their body as they go to the maker of their religion, because they want to go as they came to the world, where other people feel that they want to be at peace, and that's not a problem for them. Some people are in religions where the body needs to be draped in white cotton and facing a certain direction after death. And we need to be able to look at all of these cultural and religious practices and meet the patient's and family's needs by accommodating to the fullest extent. There's also cultural implications for pain. There's some cultures that are very stoic and don't want to show pain, or there's others cultures where it's considered okay to wail and cry when they're in pain. Birth also has huge cultural implications. For example, many of our hospitals don't even think about it when they bathe the baby once it's born. But in some cultures, the baby is not to be bathed for the first day or two. So we need to know where the patient is coming from, what their belief systems are. You'll be working with people from different cultures throughout your career, and it's important to be able to connect at some level, but to understand where other people are coming from, and understanding that we all come from different backgrounds, different perceptions, and even within the same culture, there's wide variations. The understanding of yourself and your own biases and belief system is imperative in order to be able to work with people from another culture. It's important to remember that what seems perfectly reasonable to you may be very unreasonable to them, and vice versa. I just read a book called Hillbilly Effigy. It's a short read, and it would be very good to read that, because it talks about the hillbillies in Kentucky and Appalachia, that why they believe how they believe and why they act the way they act. It's just kind of an insider's view of the culture in that part of the country. So in working with people, we need to overcome a lot of these communication barriers. And often we need an interpreter. In Kaiser, they have a telephone at the bedside where if the nurse needs an interpreter, they can call them from the bedside. So there's not actually a person in the room that's interpreting. But what you'll do is put it on speakerphone so that the interpreter can talk to you and to the patient simultaneously. In other instances, you might have an interpreter at the bedside, and in that case, you want to make sure that the interpreter is next to the patient so that when you're asking questions, you're able to maintain eye contact with the patient. Nonverbal cues and touch are seen differently in different cultures, and so you're going to be looking at nonverbal behaviors to kind of guide your communication patterns. Touching is necessary when we do a physical assessment, and it conveys different meanings in different cultures. So we're trying to convey professionalism and making sure that we are appropriate and therapeutic. Remember your heritage assessment that you did in lab, where you did the Jarvis manual assignment on page 13 and 16. There's also information in your Jarvis text on page 24, and there will be a question on the exam about this. So go and read those over again to make sure that you understand what you're getting from the heritage assessment. In conclusion, I have a closing thought. It's not exactly the quote of the week, but diversity is a way of life created when we all recognize that the whole is better because of its unique parts. In a diverse environment, an individual's uniqueness is celebrated, valued, and used to further the mission of the organization. Diversity enriches us all and takes nothing from anyone. Aww.